Hello and welcome to this episode of the Cases podcast. My name is Kieran Brown. I'm a GP in Central Sheffield and I'm one of the Haematology Cases peer assessors. I'm delighted to be joined today by Dr. Sally Keat, who is a consultant haematologist with a special interest in myeloma. Hi, Sally.
Hi, and yeah, thank you very much for inviting me to come and talk today. Thank you.
Thank you. Thank you for being here with us. Well, I'm really pleased to say one of the strengths of Cases, I think, is that we can identify learning needs from primary care across Sheffield. And one of the big areas that always comes up is around paraproteins, MGUS and myeloma. So we decided to do our podcast on this area, hopefully to cast some light on things that I think some GPs find tricky and hopefully to answer some questions that I have and that we've drawn up from some of the information that we get through Cases. So I thought I'd start by just asking you, why should GPs know about paraproteins? Why is this an important topic for primary care?
So I think there's two big reasons why paraproteins are really important in primary care. And I suppose probably the first one to say is that in terms of myeloma, which I suppose is often the reason for a test in the first place, it's still a condition where there's often a long lag between first symptoms, people present, and people getting a diagnosis. One of the longest of all the cancers still. So I think for patients where there's the first signs of a concern about myeloma, I think making sure that you send the right test and that you send it early. So I think that's probably the first thing to say. The second thing is immunoglobulins are checked for a variety of reasons, obviously other than just assessing for myeloma. And finding a paraprotein or a monoclone, terms which are used interchangeably, is quite common. And the reasons that you might find a paraprotein are they range from completely insignificant, don't need to be worried about at all, to obviously extremely significant and things that need urgent referral straight away. So I think having a framework for what you do, or at least a something in your mind for things that are going to make you worry more, I think are really important. So I think this is a really good discussion to have.
Great. So there's an opportunity to pick up an important condition earlier in primary care, but also there's a chance of some confusion when getting the results back.
Absolutely.
It's something I harp onto my registrars about is doing myeloma screens for a range of presentations. But when might a GP become aware that they should be checking a myeloma screen or an immunoglobulins for a patient?
So I think the symptoms that are real red flags for patients with myeloma are people that have had recurrent infections. So patients who have been in and out, over the last 6-12 months, and you can see that they've had multiple episodes of infection with no obvious underlying trigger for that. I think that should raise an alarm that there could be an issue with their immune function. So sending off some immunoglobulins is helpful anyway, but will also identify if myeloma is the underlying reason for that. Otherwise, patients who've got a new and unexplained anemia, usually a normocytic anemia, but an anemia that's unexplained, I think sending serum immunoglobulins electrophoresis is helpful. And of course, patients who've got new unexplained pains, particularly back pain, but not always back pain. I think back pain is probably will be the biggest group of people that are presenting with myeloma bone disease. But persistent, intractable pain that doesn't obviously follow the pattern of getting worse with exercise, pain that's worse at night. I think all of these patients would warrant having a myeloma screen sent. And lastly, patients who've got new or worsening renal failure without another obvious cause.
So those are the kind of cardinal features of myeloma, I think, that have gone through there for us, aren't they? The other thing that I always look at in primary care is patients who've got raised globulins or a raised inflammatory response, who might not be presenting with symptoms typical of myeloma, but where we can benefit from getting some more information about their protein metabolism and what's actually happening in their system.
Absolutely. Yeah, so I think that's a really important point. There may be people who are asymptomatic, who don't have any obvious organ dysfunction at all related with myeloma, where it's really important to try and pick up people who have either a monoclone or myeloma. So a raised globulin is really a useful marker there. And of course, we are used to seeing with people's liver function tests that we get back that will have a total protein that will give us all of the different protein fractions added together. Their albumin, which is often we use it as a surrogate marker for all sorts of things, but nutrition, liver are really important. But globulin, the globulin fraction will contain within it your immunoglobulins, and if it's raised, I think it should start to give a concern that there could be a paraprotein or an additional immunoglobulin that's adding into that.
Okay, thank you. The other thing we get through cases quite a bit are patients with raised MCVs, with large red blood cells. And I think in our local guidance, immunoglobulin screening is one thing that's recommended in those patients. Can I ask you why that is?
So I think a raised MCV, it's not as such a marker of, I don't think of it as something typical in myeloma as such. But a raised MCV will come with liver disease, where you will generally see polyclonally raised immunoglobulins. So it would be a useful thing to have looked at.
Thank you. A really common question I get from registrars in primary care is, if I'm doing a myeloma screen, do I have to do a Bence-Jones protein alongside?
Yeah, so I think that's a really good question, because at the moment, I would say it probably is useful to do it. So the Bence-Jones will give you an idea of whether you've got light chain being excreted and you've got an excess of light chain in the urine. In the hospital, we would do a serum-free light chain and less reliant on urinary Bence-Jones protein. But I think it is going to change probably within the nearish future, that serum-free light chains will be requestable in primary care. And at that point, I think that would supersede doing a urinary Bence-Jones protein. I suppose the other thing that a urinary Bence-Jones protein will give you is that it also gives you a urinary total protein, and that is really helpful for a number of reasons. I think if you've got a raised urinary total protein and you've got a urinary Bence-Jones protein as well, I would start to be more concerned at that point that there's some organ dysfunction there. You've got proteinuria in the context of paraproteinemia, yeah.
So something's affecting the kidneys, and that may well be myeloma.
Exactly.
Okay. Great. I'll ask you a bit more about the serum-free light chains now, if that's okay, because I think that's in other areas of the country, I'm aware GPs have had access to that reporting for a little while, and I think it's an area that certainly we'd feel less confident about requesting and interpreting those results. Are there plans for that to be rolled out to primary care in Sheffield, and if so, how and where would that test be used to complement immunoglobulins?
So I think there is a plan that will be rolled out. I don't know when, but I think that is something that will hopefully be coming. Asking for serum-free light chains for, I think in patients where the concern is that they might have myeloma, where you're sending it a myeloma screen, I would always send serum electrophoresis and serum-free light chains, because there's probably more than 10% of patients with myeloma they only secrete light chain. They won't have a paraprotein at all. You're right again in saying that the serum-free light chain is probably not quite so straightforward to interpret, because with the immunoglobulins, you will have something abnormal in addition. You'll have your immunoglobulins, your normal immunoglobulin subclasses, and then in addition, there will be a monoclone. which is always abnormal, and they will give you a quantity for that. And in the serum-free light chains, we look more at the ratio between the two. The kappa and the lambda is much more important than the actual number of each themselves, because there will be conditions like people that have got renal impairment for any other reason who won't be secreting light chain normally, who will have raised both kappa and lambda. So you'll see both of them being higher than normal, but actually the ratio between the two of them is still normal. Whereas with a true clonal problem like myeloma, you will see one of them will be elevated. So there'll be a discrepancy between them, and that will affect the ratio. So in terms of our guidance for who gets referred in when, there is guidance on with the serum-free light chains, as much as there is for the amount of the monoclone. The degree of how abnormal that light chain ratio is important as well. And I think for a ratio of above 7 or less than 0.1, that should be triggering a referral.
I can hear GPs panicking listening to this as we speak. So I can feel a second episode of this podcast coming along once we have access to this.
Yeah.
I think that is really important. That will be reflected in the guidance that we have available through the press portal or whatever it will be that replaces that when that comes around. And I think there'll be a lot of anxiety around interpreting those results in primary care.
Yeah, and I think using the haematology advice and guidance, hopefully that will be a useful resource as well in those situations. Result, it was sent for this reason. Do I need to worry about this? Does this person need seeing at all? So I think when that is rolled out, there will be some guidance on exactly when to use it and then what to do with the result. And then whilst that's all bedding in and people are just getting used to using it, I think using the advice and guidance service to say, do we need to refer this patient in? Or is this something that we need to worry about at all?
Absolutely, and hopefully cases will have a role in that as well, taking up some of those referrals too. Okay, moving on a little bit then. So one area that we get a lot through cases are patients who have a polyclonal gammopathy, an abnormality on their immunoglobulins that's not suggestive of a hematological condition. It's probably a little bit out of the scope of what you do in outpatients clinic, but how would you recommend a GP approaches that? Was there anything that we should be thinking about?
In terms of the causes of a polyclonal rise in immunoglobulins, there's lots of things that can feed into that, and I think liver disease is probably one of the big causes of a polyclonal rise in immunoglobulins. So I suppose a screen in terms of the history and the drugs of things that could be causing a chronic liver disease will be important to think of initially. In terms of other things, any inflammatory condition and autoimmune conditions particularly can cause polyclonal increases and malignancies as well. So not just hematological malignancies, but any solid malignancy can cause polyclonally increased immunoglobulins. So the potential causes are really wide, but I think making sure they've had liver function tests done and some inflammatory markers as well to see whether this looks like it's going down more of an inflammatory infective route, or whether this could be something like liver disease autoimmunity.
Yes. So quite often through cases we'll send back advice to check liver functions, maybe think about a non-invasive liver screen if they've got abnormal LFTs. We'll be thinking about things like an autoimmune screen in primary care. And then in the cohort that I look after here, as well, particularly blood-borne viruses and tuberculosis can cause a polyclonal increase in immunoglobulins. We've got a couple of patients here who've been diagnosed with HIV purely based on their immunoglobulin results when it wasn't suspected for other reasons. So it's worth bearing in mind that kind of broad spectrum of conditions. And I think cases can be helpful there if you're just struggling to get your head around why that might be. Send us their medical history, send us their medication list, send us their recent results, and we can help formulate a plan for further investigations. And then where things are medically complex, we still use the haematologists to give us advice as well. So we'll often send on referrals where we don't know the answer to questions, even if they're not truly hematological in nature.
Yeah.
Thank you, that's really helpful. Super. So then there's a few specific patterns that we get, and I'm probably itching to get on to talk about myeloma a little bit more here, really, because I'm asking you all the things that stay in primary care. There's one specific pattern that I see that causes me a bit of anxiety, and that's IgM monoclones, because they're thought about a little bit differently, as I understand it.
Yeah, and I think they cause everyone a bit more anxiety, I think, because it's often less clear what might be causing it. So with IgM specifically, it'll still be a clonal cause. All of these monoclones, they will come from a plasma cell clone within the bone marrow. Or yeah, not necessarily within the bone marrow, but a plasma cell clone within the body. But with IgM, we think particularly about lymphomas or lymphoplasmacytic lymphoma, also called Waldenstrom's, more than we do with myeloma. It's much more common that would be the case than it would be an IgM myeloma, which is still an entity, but is very rare. So when you see an IgM monoclone, I think making sure that you've asked those sort of screening questions that you're really used to asking about the more lymphoma style questions of weight loss, sweats, nodes. I think making sure that sort of B symptom screen is done for patients where there's a new IgM monoclone. We do quite frequently see trace IgM monoclones that then just go away, and they seem to be just a reactive phenomenon. So on all the guidance, it's always if you see a monoclone, if at a level with no other obvious clinical symptoms, is making sure that they're repeated, because some of these do just disappear with time.
And that you'll be repeating, say, 3 months or so.
Exactly. Yeah.
Okay. Yeah, certainly from my point of view in cases, I'm much more likely to pass on a low-level IgM paraprotein, and I suspect GPs should be aware to refer with a lower threshold in that scenario than they might with other groups.
Yeah, and I think that's completely legitimate.
Great, thank you. Another pattern that causes me headaches are sort of oligoclonal patterns and biclones, so not a straightforward monoclonal or polyclonal picture. Do they require specific actions or attention?
So I think oligoclonal I would probably still put in the same bracket with the polyclonal, and I think repeating to see if you're consistently getting the same pattern, I think is reasonable. With the biclones, I would treat them just as a monoclone. So with a biclone, what you're seeing there is you just have two distinct plasma cell clones coming from the marrow. And that doesn't put you at higher risk of progression, so you can still have an MGUS and just have, but it's with two clones rather than just one. Generally what the lab will do is they will add those two clones together. So some labs will just add them together and they will give you a total result. In Sheffield, they will always tell you that there's several clones, and they will then tell you they'll go by the biggest one. So if you've got a clone of 1 and you've got a clone of 0.5, sorry, a clone of 1 and 1 of 0.5, the clone of 1 will be the one that they quote, but they'll tell you that there are 2. But it doesn't confer a higher risk, to my knowledge, of someone progressing or more likely to have myeloma or something else going on. It can still be an MGUS.
Okay, that's helpful. So oligoclonal is more likely to be a reactive picture. We can safely repeat that in 3 months and maybe take advice if it persists and look for other causes. The biclones that we see, we should treat almost as a monoclone. Yeah. With the largest clone being the
dominant clone.
The relevant one to look at. Thank you, that's really helpful. Okay, so getting on to the core of this then, so the MGUS monitoring and when we should recognise MGUS, when we should refer, when we could be monitoring this in primary care. I think this is something that causes GPs a little bit of stress and some headaches. So if we get a report showing a monoclone in a patient, perhaps where we weren't expecting it, and we'd done the test for another reason, and we think they're at low risk of myeloma, they don't have an unexplained anemia, they don't have progressive renal failure, they don't have any bony pain, and perhaps their bone profile is normal if we've done that as well. How should we approach that in primary care?
So in those patients, I think 2 important things to look at first off. So do they have immune paresis? So they've got a monoclone, but are the rest of their immunoglobulins normal? If you're seeing someone who's got a monoclone and has a reduction in all of their normal immunoglobulins, that's a worrying sign, and those patients should just be referred. So a monoclone and immune paresis should be referred. Patients who've got a monoclone and otherwise they've got a fairly normal looking immunoglobulin profile with no other abnormal features, the size of the clone becomes important. So for an IgG, we would set our guidance and the national guidance from the British Society of Haematology is that an IgG monoclone of less than 15 grams can be monitored. They don't need an immediate referral, and less than 10 for an IgA and an IgM. So it's slightly different for the IgG versus the IgA and the IgM. For patients who they've got a monoclone of above 15, if it's IgG, or above 10, if it's IgA or IgM, should be referred straight away.
Okay. And so if they have the low level paraproteinemia, so below 15 for IgG, below 10 for the others, and we've assessed the patient, we think they're at low risk of being unwell, having features that point towards myeloma, then we could be monitoring those in primary care. We can make the presumptive diagnosis of MGUS ourselves as GPs.
Yes.
What should we do next?
So we would, I think, if that GP feels happy to do that, then I think the next step is making sure that they have their monitoring done. And I think I would start with every 3 months to start with. And that's making sure that you're not seeing a progressive rise in that monoclone. So a rise of more than 25% or 5 grams, whichever, if you've got a low level monoclone, then actually 25% will come quicker. If you're seeing that, then they need referring in because that is someone who you're worried is actually starting to progress or show signs that they're someone who may progress early. If you're monitoring every 3 months for the first, that should be for the first year, you're seeing no progressive rise in that monoclone. All of the rest of their blood tests are reassuring. There's no anemia, there's nothing else that is of concern. Then they can continue with community monitoring. That monitoring can get less frequent over time, going down to every 6 months. And for patients who have remained stable for several years, that can go down to yearly after that. There is a risk stratification tool which you can search for, the Mayo MGUS risk stratification tool, which will look at the size of the monoclone and the other immunoglobulins, and it will give you a risk status as to what their risk of progression is. In clinic, for most patients, I will do their risk score when I first see them. And for many patients, if they're low level, I would be happy for that person to be monitored in the community.
Okay. So that's probably the majority of patients with MGUS could be monitored in primary care. There's a couple of pitfalls to watch out for there, isn't there? So I think the rise of 25% is really important. I'm not sure how strongly that's represented in our local guidance as well, but it's that trend towards a rising paraprotein level. Are there any other things that while we're monitoring we should look out for and refer at that stage if they occur?
I think probably the most important thing clinically will be infections. So if someone's getting recurrent infections, then I think there's a sign there that their immune function is not what it should be. And I think referring for review is very reasonable. For patients who are getting new pains, of course, any of these sort of crab features of myeloma, they should be referred in. And anyone who develops immune paresis, so develops low immunoglobulins with a monoclone, should also be referred.
Great. And for anyone who's not come across the crab thing since medical school, that's raised calcium, worsening on renal impairment, anemia, or bone pain.
Exactly, yeah.
Great. Thank you very much. This is one of these things that we're quite good at as GPs in terms of holding risk, explaining this to patients, having these conversations with our patients. But any condition where there's a low but no risk of a serious condition can cause anxiety for patients. Is there any tips on how we have those conversations, or any resources we can use with patients to try and make those conversations go as smoothly as possible?
I think it is a really difficult discussion to talk about a essentially precancerous condition which we're just monitoring with blood tests, and I think it does cause quite a significant degree of anxiety for patients. I think in terms of the information to give regarding progression for patients that have got a low risk, we would be estimating that risk as about 1 in 100, 1% per year of progression, and that's every year. And I think people often find that quite useful as a way of trying to conceptualize that risk of progression, because it is a low risk of progression over time. I suppose the other thing is making sure that people feel they're well informed on what symptoms they should be looking out for. So things like back pain that's just not settling with pain relief, infections, that those are important symptoms to highlight and raise, and that those could be features of something more significant going on. But it is also important to say that most patients in fact with MGUS won't progress and will remain having MGUS, and that, you know, their whole lives, without ever progressing to myeloma. The Myeloma UK website I think is really good, and they've got a good information leaflet on MGUS, which I think all patients should have. Website has lots of photos of patients who feel comfortable to use it. I think it is a good resource.
Yeah, I use that with patients, and I use that with cases. I send that often back with guidance about MGUS as well. It is really great. Sending a website that says myeloma can be a little bit nerve-wracking for patients, but beyond that, I think it's a really valuable resource to have. That's really helpful. I think that's addressed most of the things that I find as a GP cause me a little bit of anxiety when I'm monitoring these patients in primary care. In our practice, we do tend to monitor our MGUS patients, and are happy to make diagnoses and do the initial monitoring ourselves. I think it's always important to say there is lots of backup available if you are doing that. That cases can help. We're always happy to look at results and give advice on how we might manage our patients in primary care with a little bit more exposure to these things. And we have a low threshold for passing these things on for advice from a haematologist, because they're important conditions to get right. Thank you very much. Are there any sort of key points or things that you think primary care clinicians should take away from the podcast today, or any things you'd like to reiterate that are the key points from today?
I suppose there's a couple of things that we haven't spoke about in terms of, we've talked about MGUS and we've talked about a little bit about myeloma, but just that the patients with monoclones, it can be other conditions. So things like amyloid, obviously incredibly rare, but for patients who have a very low level monoclone, particularly if it's a lambda monoclone with proteinuria or, you know, unexplained symptoms, I think sometimes even though it's a low level monoclone, if there are other things that are making you worried, and particularly things like urinary protein, it's a very good thing to hand on to cases, and we would usually be happy to see these patients as well if there's a concern. And for patients with renal impairment, most of these patients will get referred straight away, but some of these monoclones can be a monoclonal gammopathy with some other significance, so either a neuropathy or of renal significance. So I think if there are concerns about someone with developing renal impairment, if they've been labelled as an MGUS before, because they would be probably referred on as a query myeloma anyway, but some of these patients may have some of these other associations. So just things to keep in mind. And we're always very happy to see people and advise if wherever is helpful.
Great. Thank you very much. That's really helpful. A couple of really rare things at the end that causes a load of anxiety as GPs, but it's that key message, isn't it? If it's out of the ordinary, if the patient's symptomatic and you can't get to the bottom of it, then refer. Exactly.
I think if there are concerns and it just doesn't quite hang together and it doesn't feel right, very happy to see. But they are very rare, but just worth not forgetting about.
Great. I think all that remains then is to say a big thank you to Dr. Sally Keat, and thank you for listening.
Thank you.